Hello, good day everyone. Again, this is Sir Carl, your preceptor for Microbiology and Parasitology. So for today's discussion, we'll discuss bacterial and fungal infections that affects organ system. So these are just the common bacterial and fungal infections. So let's start with skin. So the most common infectious diseases that affects the skin, particularly bacteria, is your acne. I guess most of us, okay, experience acne, especially the when we are teenager. So your acne is caused by a bacteria known as your Propionibacterium acnes, which is an anaerobic dipteroid, which is commonly found on the skin. So this organism class has a nutritional requirement for glycerol in sebum. So what is sebum? Sebum is produced by your sebaceous gland that help the skin protect against the friction and make it more impervious to moisture. So your P. acnes, as I mentioned, has nutritional requirements for glycerol in sebum. It metabolizes in sebum, which forms free fatty acids that causes inflammatory response. That is why you will see formations, okay? Acne formation. Neutrophils that secrete enzyme damage the wall of the hair follicle are attracted to the site. The resulting inflammation leads to appearance of pustules and papules. So, usually, the signs and symptoms of your acne is inflammatory lesions or originating with accumulation of sebum that ruptures a hair follicle. So, portal of entry of your organism is your sebum channel. So, usually the treatment class includes your benzoyl peroxide, isotretinoin, and azelaic acid. So, your acne is a condition also in which pores become clogged with dried sebum, flake skin, and bacteria, which leads to formation of blackheads and whiteheads that are inflamed and infected with abscess. So that is why you will see follicles here and pustules rather. Okay. The next bacterial infection is your anthrax or your Walters disease. So your anthrax or your Walters disease is caused by Bacillus anthracis. So Bacillus anthracis is an encapsulated spore-forming gram-positive bacillus. Okay? So as mentioned, it is encapsulated, it is spore forming, so one of the virulence factor of your organism is endospores capsule. It also contains lethal factor and edema factor which aids in pathogenesis. So your Bacillus anthracis can cause cutaneous, pulmonary, and gastrointestinal anthrax. So for cutaneous anthrax, the lesion begins with pruritic papules that enlarges to form an ulcer surrounded by a vesicle and then develops into an eschar. This one, a black eschar. So a eschar is a black and crusty collection of dead tissue that sheds off from the skin. So eschar is developed as a result of necrotoxin. So as I said a while ago, you have two factors, your little factor and edema factor. So these produce toxins. So again, clinical features of your anthrax for cutaneous is the formation of your eschar. So for diagnosis, you will have microscopy and culture of the vesicle. So one of the distinguishing characteristics of your anthrax when you go for culture is the appearance of medusa head colonies. Okay, so this is an appearance of medusa head colonies on a blood agar plate. So left untreated, anthrax, even the cutaneous form of anthrax is fatal. So reported says that 20% of the time, it can cause death. So for treatment of your anthrax, you have your ciprofloxacin, doxycycline, and levofloxacin. So in prevention for anthrax class is avoid contact and use standard precaution always. Vaccines is also available but not widely used. The next one is your gas gangrene or your Clostridial myonecrosis. Your gas gangrene or Clostridial myonecrosis is caused by Clostridium species, in which the most common is your Clostridium perfringens. Okay? So, the reservoir of this organism is soil. So, human becomes infected when soil containing Clostridial spores enters an open wound. Usually, your Clostridial myonecrosis occurs following muscle injury and contamination of wound by soil or foreign materials containing the spores. Remember, your Clostridium perfringens class virulence factor is alpha and gamma toxin. So these toxins are responsible for the destroying of muscle and soft tissue, allowing the deeper penetration of the organism. So the pathological effect of your organism class is mediated by the effect of these toxin. So common signs and symptoms, you have the fever, tachycardic, hypotension, jaundice, and renal failure. So diagnosis includes clinical history, gram stain of wound or aspirate, liquid anaerobic culture, since this organism is anaerobic, and plain radiographs which shows gas in the affected tissue. So, management for this type of infections includes surgical expiration and debridement of the affected area. So, you can also give antibiotics like piperacillin tazobactam plus vancomycin if you suspect MRSA or penicillin and clindamycin. The next bacterial disease is your leprosy or your Hansen's disease. So your leprosy or Hansen's disease was first described by Hansen in 1873. That is why it's called Hansen. 9 years before the Koch's discovery of tubercle bacillus. So it has not been cultivated on a non-living bacteriologic media. So your leprosy class is caused by Mycobacterium leprae, which is under also the same with Mycobacterium tuberculosis. So Mycobacterium leprae is present in nasal discharges and shed from cutaneous lesion. The exact mode of transmission has not been clearly established, but the organism invades peripheral nerves and skin cells and become obligately intracellular parasite. So the clinical signs and symptoms for this one is circumscribed, hypopigmented, or less commonly hyperpigmented macules. So you have two types of leprosy class. You have your tubercular leprosy or your paucibacillary leprosy and your lepromatous or multibacillary leprosy. So your tuberculoid leprosy is localized and benign and the immune response is effective. So, common signs and symptoms for tuberculoid are skin lesions and damaging of the nerves. By the way, when we say paucibacillary patients are those who are skin smear negative and show no evidence of more advanced disease on a biopsy. Okay? So, lepromatous leprosy is a disseminated, malignant, and the immune response is ineffective. So, the common signs and symptoms for this type of leprosy is facial and nasal deformities. So, this is multibacillary, meaning the patients are those who are skin smear positive and or having a biopsy indicating more advanced diseases. So in order to distinguish the two types of leprosy, lepromine test is being used. So tuberculoid is positive for lepromine test, while lepromatous is negative for lepromine test. Also, PCR has been used nowadays in order to diagnose this type of infection. So, according to reports, class 90% yield positive for lepromatus, again 90%, and 34% for tuberculoid. So, the treatment includes your dapsone, clofazimine, and rifampin. Another skin infections associated with bacteria is your impetigo. Impetigo is a superficial bacterial infection that causes the skin to flake or peel off. It is not a serious disease, but it is highly contagious and children are the primary victims. Impetigo can be caused by either your Staphylococcus aureus or your Streptococcus pyogenes or your group A strep. Or, in some cases, class are probably caused by a mixture of the two organisms. It has been suggested that your Streptococcus pyogenes begins all cases of the disease, and in some cases, S. aureus later takes place over and become the predominant bacterium cultured from the lesions. Because your S. aureus produces a bacteriocin, which is a type of toxin that can destroy Streptococcus pyogenes, it is possible that Streptococcus pyogenes is often missed in culture-based diagnosis. So, your Staphylococcus and Streptococcus infections are both transmitted by a direct contact and indirect contact. So, you have there the virulence factor. For Staphylococcus aureus, you have there the exfoliative toxin A, coagulase, and other enzymes. For Streptococcus pyogenes, you have there the streptokinase, hyaluronase, and your M protein. Your M protein is the major virulence factor per Streptococcus pyogenes, while your Staphylococcus, you have the coagulase, is the major virulent factor. So, in order to distinguish the two class, you need to perform biochemical tests. So, catalase test, positive for Staphylococcus, negative naman si Streptococcus. Impetigo, whether it is caused by your Streptococcus pyogenes or Staphylococcus aureus or both, is highly contagious and transmitted through direct and indirect contacts. Vaccines are also available or in development rather for both of the etiologic agents, but none are currently available. So, there are studies class na gumagawa naman sila ng vaccine for this type of infections kasi nga common siya for the children, but it's not used pa. Okay? So far, the treatment of choice for impetigo for Staphylococcus, you have their oral medications like decloxacillin, cephalexin, okay? And for Streptococcus, you have the topical mifepristone or rifampicillin. The next bacterial infection is your cellulitis. So, cellulitis is a condition caused by a fast-spreading infection in the dermis and in the subcutaneous below. It causes pain, tenderness, swelling, and warmth. Fever and swelling on the lymph nodes draining the areas may also occur frequently. Red lines leading away from the area are visible. So the symptoms is the result of microbes and inflammatory products being carried by the lymphatic system. Bacteremia also could be developed with the disease, but uncomplicated cellulitis has good prognosis. So, cellulitis can be caused by either staph, aureus, Streptococcus pyogenes, or other bacteria or fungi. So, these are introduced into the dermis either through trauma or by subtle means with no obvious break in the skin. So, the most common cause of the condition in healthy people are your Staphylococcus and your Streptococcus. In infants, your group B strep are frequent cause. Your group B strep, by the way, are your group B Streptococcus agalactiae. So, Treatment of choice, you have oral or IV drugs there on the table. So if you notice, they have the same virulence factor with Impetigo. So diagnosis is based on clinical signs. Mild cellulitis naman class responds well to oral antibiotics. It should be chosen lang effective against both Staph aureus and Streptococcus pyogenes. So other treatment management includes IV antibiotics, or if there are intensive areas of damage class, it may include surgical debridement or other management. Next is your Staphylococcal scalded skin syndrome. From the name itself, staphylococcal, so it is caused by your staph. So this syndrome is another dermolytic condition caused by Staph aureus. It affects mostly newborns and babies, although children and adults can also experience the infection. So transmission class may occur when caregivers carry the bacterium from one baby to another. So that is why as nurse, you should be careful when working on a nursery. Adults in the nursery can also direct transfer S aureus because approximately, according to reports, class 30% of adults are asymptomatic carriers of staph. So that is why in some hospitals class there are nasal screening periodically for nurses that are assigned in a nursery or neonatal intensive care unit to check whether that nurse, that particular healthcare worker, is a carrier of Staphylococcus aureus. So, carriers can harbor the bacteria in nasopharynx, axilla, perineum, and even in the vagina in some reported cases. So, your Staphylococcal scalded skin syndrome, like Impetigo, is also an exotoxin-mediated infection. So, the virulence factor is exfoliative toxin A and B. It's a phage-encoded exfoliative toxin responsible for the damage. So, unlike Impetigo class, your skin scalded syndrome, toxins enter the bloodstream from some focus of infections like throat, eyes, or some an Impetigo infection, and then travel to the skin throughout the body. So, these toxins causes bullous lesions which often appear in the first around the umbilical cord for neonates or in the diaper or axilla. A split of the skin occurs in the epidermal tissue layer, just like this in the picture, above the stratum basale. So, stratum basale, review your histology or your human ana. Where can you locate stratum basale? So, a widespread desquamation of the skin class follows, leading to the burned appearance referred into the name scalded syndrome. So, once a tentative diagnosis for staphylococcal skin scalded syndrome is made, immediate antibiotic therapy should be instituted. So, antibiotics include your nafcillin, if sensitive, vancomycin for MRSA suspected patients. Again, for MRSA, usually this is a threat to hospital. Okay, so if you have patient with MRSA, standard precautions should be followed. Universal standard precautions should be followed. Another skin infection is your necrotizing fasciitis. So, necrotizing fasciitis is most commonly affects the lower limb but may affect other parts of the body. So, the affected area is usually red, hot, swollen, and exquisitely tender and painful. So, there is also rapid progression with skin discoloration, crepitus, bola formations, and cutaneous gangrene like this one. So, you have different causative agent for necrotizing fasciitis. For type 1, it is usually caused by anaerobes like your Streptococcus or your Bacteroides, as well as your facultative anaerobe, that is group A strep, and some Enterobacteriaceae like your Proteus. Your type 2 necrotizing fasciitis is caused by your group A Streptococcus. So that is why for group A Streptococcus, if necrotizing fasciitis in some textbook, it is referred as flesh-eating bacteria. So your type 2 necrotizing fasciitis can be caused by group A alone or in combination with Staph aureus. Again, in combination with Staph, because Staph again is a normal flora of the skin. So since this is a skin infection, so the mode of entry is usually skin abrasion, so direct contact. So diagnosis includes surgery for wounds, microbiology techniques like gram stain and culture for deep tissues, histopathology, which includes biopsy, and imaging like X-ray, CT scans, or MRI scans that reveals gas formations. So management includes surgical debridement, antibiotics like your tazobactam, and clindamycin. You will add vancomycin again if there is MRSA, and specific therapy if ever group A strep is really the causative agent. So you'll add penicillin and clindamycin. So we're done with common bacterial infection. Now let's go to fungal. So the most common fungal infection is your dermatophytosis or dermatomycosis. So you have their ringworm or your tinea, a group of fungi that is collectively termed dermatophytes, causes a variety of the body surface condition. These mycosis class are strictly confined to the non-living epidermal tissue and their derivatives like hair and nails. All these conditions have different names that begin with the word tinea or ringworm, which derives from erroneous belief that they were caused by worms. But these are not worms class. These are not caused by worms. Instead, these are caused by fungi. So that misconception is also the reason that these diseases are called ringworms, but don't confuse tinea terms with genus and species name. It is simply an old practice for naming the condition. So let's just have a review. If you have ringworm on the scalp, you call it as tinea capitis. So this one, tinea capitis. Ringworm of the beard, you have your tinea barbae. This one. This is common among male, okay, or barber's itch, as we call it. Ringworm of the body, we call as tinea corporis. So this is prevalent on human that can appear anywhere of the body. You also have ringworm of the groin area. So this is also known as jock itch here in the groin area. So we call it as tinea cruris. So this is common among male on the groin, perianal skin, scrotum as well. You can see this one. Ringworm of the foot. So this is commonly known as athlete's foot. So we call it as tinea pedis. And ringworm of the nail or your tinea ongium. So here, the picture. Fingernails and toenails being masses of keratin are often sites for persistent fungus colonization. So usually, you will see thickening and distortion and darkening of the nails for this type of infection. So the diagnosis for tinea class caused by some species is aided by the use of long-wave ultraviolet lamp that causes infected parts to flourish. Samples like hair, skin scrapings, and nail debris treated with heated potassium hydroxide show a thin branching fungal mycelium if infection is present. So the common diagnostic tool for this type of infection class is the use of potassium hydroxide. Again, potassium hydroxide is the common diagnostic tool for your tinea infection or ringworm infection. So here on the table is just a summary of the cutaneous and superficial mycosis. So cutaneous mycosis, you have there your trichophyton, microsporum, and epidermophyton are the most common causative agent. Your superficial mycosis is caused by Malassezia species. So what is cutaneous infection? So cutaneous, there are approximately a lot of organisms that causes cutaneous, but the most common again are your three organisms, your TEM, your trichophyton, epidermophyton, and microsporum. So these are still dermatophytes class which have the ability to invade and digest keratin, okay, which are the naturally abundant in cell of the stratum corneum. They have also been found to suppress the ability of the immune system to respond them, ensuring their long-term persistence. So the fungi do not invade deeper epidermal layer. Superficial infections naman, you have the agent of superficial mycosis involves the outer epidermal surface and ordinarily infections with cosmetic rather inflammatory effect. So these are fungal infection of the outermost area of the body, including outer surface of the hair, shafts, and the epidermal layer of the skin. So superficial mycosis includes your otomycosis, like your black piedra, your white piedra, and your tinea versicolor. So us people were makikita natin is the tinea versicolor, or in layman's term we call this as up. So this is caused by your Malassezia, particularly your Malassezia furfur. So tinea versicolor is caused by yeast genus under Malassezia. The yeast class feeds on the high oil content of the skin glands, and even though these yeasts are very common in some people, its growth elicits mild, chronic scaling and interferes with the production of pigment of melanocytes. So commonly, these are seen sa mga trunk, face, and limbs and may take on the mottled appearance. So, di ba? Common, makita natin to sa mga likod natin, if ever. So, treatment for this type of infections include topical agents, particularly antifungal agents. Again, in diagnosing SIDS is superficial and cutaneous mycosis, KOH stain is being used. Now let's go to bacterial infections of the ear. So, number one is your otitis externa, or your external otitis, or your ear canal infection, or your swimmer's ear. Otitis externa is an infection of the outer ear canal with itching, pain, a malodorous discharge, tenderness, redness, swelling, and impaired hearing. So, otitis externa is most common during summer swimming season. That is why it's known as swimmer's ear. Trapped water in the external ear canal can lead to wet, softened skin which is more easily infected by bacteria or fungi. So the most common causative agent for swimmer's ear class is your Pseudomonas aeruginosa, which is a gram-negative bacilli. But your otitis externa can also be caused by gram-positive organism like Staph aureus, your group A strep, your E. coli, and some fungi like Aspergillus and Candida. So, otitis externa is referred to swimmer's ear because it is often result from a swimming in water contaminated with the organism, particularly again with Pseudomonas aeruginosa. So, reservoir of your otitis external infection includes contaminated water, swimming pool, sometimes endogenous microflora, or articles inserted into the ear canal for cleaning out debris and wax. So you have three common clinical features of otitis externa. You have your acute localized otitis externa due to pustules caused by Staph aureus, or erysipelas due to group A Streptococcus. So for this one, the management is surgical drainage. For acute diffuse otitis externa, you have the canal skin becomes erythematous red, itchy and painful, and the most common causative agent is your Pseudomonas aeruginosa. So the treatment and management for acute diffuse otitis externa is irrigation with saline plus alcohol or acetic acid, or antibiotics like neomycin eardrops or oral antibiotics. Your organism also may cause invasive infection. So invasive otitis externa causes severe necrotizing infections, which is caused by Pseudomonas aeruginosa, and these are commonly seen in elderly and immunocompromised patients. So, clinical features of invasive otitis externa is pain and tenderness if the tissue around the ear canal, and pus or discharge from the canal. So, treatment of choice, you have your anti-pseudomonal antibiotics plus systemic therapy. You will also have necrotic tissue removal and topical steroids if ever the organisms really invade the deeper tissue. If you have otitis externa, you also have otitis media, so middle ear infection. So, otitis media often develop as a complication of the common cold or common cold virus, or what we call as rhinovirus. So, aside from otitis externa, otitis media is caused by Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. So, the most common is your Streptococcus pneumoniae. So, for pathogenesis of this infection, there will be dysfunction of your Eustachian tube. This one, here, the blue part. Okay? The Eustachian tube is an arrow passage leading from the pharynx to the cavity of the middle ear. Due to the mucosal congestion caused by your virus, your common cold virus, it leads to accumulation of middle ear secretion. Once there is already secretions or fluid class, it provides bacteria hospitable for living. Okay? So, clinical features for this type of infection is persistent and severe earache, temporary hearing loss, pressure in the middle ear, and bulging of the eardrum. So, diagnosis includes pneumatic otoscopy, tympanometry, and culture, but culture is not usually done for this type of infection. Otitis media may lead to rupture of eardrum if not addressed earlier. It will also cause bloody discharge and pus. So severe complication for these type of infections includes bone infections, permanent hearing loss, meningitis as well, because again, your ear is near to your central nervous system. So treatment of choice for otitis media includes amoxicillin and coamoxiclav or ceftriaxone. Coamoxiclav and ceftriaxone is given to cover gram-negative organism. But if ever the organism is caused by Streptococcus pneumoniae, which is a gram-positive, you can just give amoxicillin. For chronic suppurative otitis media, microsuction should be done plus antibiotic treatment like amoxicillin and metronidazole. Next one is your bacterial and fungal infections of the eye. So, the most common bacterial infection of the eye is their conjunctivitis. So, the table here shown the most common bacterial diseases associated with conjunctivitis and their pathogen. Okay, so your pink eye conjunctivitis is caused by Haemophilus influenzae, subspecies Aegyptius, and your Streptococcus pneumoniae. Inclusion conjunctivitis and trachoma is caused by Chlamydia trachomatis, and gonococcal conjunctivitis is caused by Neisseria gonorrhoeae. So what is conjunctivitis? Conjunctivitis class is the most common ocular inflammation and may be primary or locally infection or part of systemic infection. Conjunctivitis is the inflammation of the conjunctiva. Okay, and the most common causative agent for this one is your Haemophilus influenzae, subspecies Aegyptius. So, let's discuss Haemophilus influenzae first. So, Haemophilus influenzae class is a gram-negative organism, and the common signs and symptoms for bacterial conjunctivitis or your pink eye conjunctivitis is reddening of the conjunctiva, edema of the eyelids, mucopurulent discharge, and sensitivity to light. Your inclusion conjunctivitis or your chlamydial conjunctivitis, this is common in neonates. Acute chlamydial conjunctivitis with mucopurulent discharge may result to scarring of conjunctiva and cornea. So, the mode of transmission for inclusion conjunctivitis is via contact with genital discharge of infected people, contaminated fingers to eye, infection in the newborn via infected birth canal, or non-chlorinated swimming pools. Your trachoma, still, this is caused by Chlamydia trachomatis. Trachoma class, by the way, is a highly contagious, acute, and or chronic conjunctival inflammation resulting to scarring of the cornea and conjunctiva or deformation of the eyelids leading to blindness. So, the mode of transmission is most likely the same with other bacterial disease that causes conjunctivitis. So, it includes direct contact with infectious ocular or nasal secretions or contaminated articles. Or, your trachoma also, if you notice here, flies. So, flies will serve as mechanical vectors. So, since this is bacterial infection, these are treated using antibacterial agents. For gonococcal conjunctivitis, or gonorrheal ophthalmia neonarum is associated with an acute redness and swelling of the conjunctiva and purulent discharge. So, the mode of transmission for this type of infections is via contact with the infected birth canal during delivery. Adult infections can result from eye to finger contact with infectious genital secretion. But again, ophthalmia neonatorum class is common for children or mga babies, rather, newborn. Okay, so these are treated using antibiotic eye drops, usually erythromycin. Before, these are treated with silver nitrite. So, another eye infection is caused by your fungi. You have the fungal keratitis. So, keratitis is inflammatory of cornea. So, there is inflammation of the cornea. So, the most common causative agent for fungal keratitis is your fusarium. So, common signs and symptoms for fungal keratitis is a red and painful eye. You also have excessive tear and discharge and sensitivity to light. So, like in the picture. So, diagnosis for fungal keratitis includes corneal scrapings like biopsy for microscopy and culture. So, here you will see culture of the fusarium and the microscopy. So, this is the microscopy. This is the organism, okay, under the microscope for fusarium. For fungal keratitis class, topical agents can be used like amphotericin, flucytosine, fluconazole, and itraconazole. But there are reports class for Fusarium, it shows resistance to many drugs. So antifungal drugs are not effective against some of these pathogens. So it may require systemic therapy in combination for topical treatment if ever the organism is resistant to the antifungal agent. So now let's go to the bacterial infection of your upper respiratory tract. So number 1 is your diphtheria. So diphtheria class is a potentially serious upper respiratory tract disease. This is an acute infection and a contagious bacterial disease primarily involves your tonsils. Okay? So here, the tonsil area. Your pharynx. Bacterial disease primarily involves the membranes of the skin, conjunctiva as well as vagina, but the most common is your pharynx. The most striking symptoms of this disease class is characterized by a membrane called pseudomembrane that forms on the tonsils or pharynx. This one, your grayish membrane. This is your pseudomembrane. So this is the clinical feature of your diphtheria. By the way, diphtheria is caused by a toxigenic strains of Corynebacterium diphtheriae. So the characteristics of the pseudomembrane, this one, is tough, asymmetrical, adherent, and color is usually gray to white membrane in the throat surrounding the inflammation. So in order to avoid this one, there is toxin already available for diphtheria. You have the diphtheria toxoid vaccine, which is part of the DTaP vaccine or the Tdap or the TD vaccination. So mode of entry for this type of infection class is usually direct contact or indirect contact, or it can be droplet contact. So in order to diagnose this one, you may use culture using Tellerite medium agar, which is the colony are color gray or black colonies. In order to treat diphtheria, you need to give oral antibiotics like penicillin and erythromycin. Another bacterial infection that affects your upper respiratory tract is your Streptococcal Pharyngitis or strep throat. This is caused by your group A strep or your Streptococcus pyogenes. Okay, so the mode of transmission rather is through droplet or indirect contact. So strep throat class is an acute bacterial infection of the throat with soreness, chills, fever, headache, and a beefy red throat. White patches can also be seen. These white patches are pure pus on the pharyngeal epithelium. You will also see enlarged tonsils. By the way, these are your tonsils, ha? This is not the tonsil. This is your uvula. These two here are your tonsils. So for strep throat, you will see enlarged tonsils with white patches. So white patches are the pus formation. So untreated strep throat can lead to complications such as scarlet fever, rheumatic fever, or post-streptococcal glomerulonephritis. So although the group streptococcal pharyngitis can be treated with penicillin, cephalexin, and cephalexin. Cephalexin is given for patients that are allergic to penicillin. So, in order to diagnose this one, culture can be used. So, you will see beta-hemolytic organism on a blood agar plate. You can also use rapid antigen tests using ASO titer. So, this antigen test is used to diagnose immunological complications. So, arise on this, like, there is an increased number of the titer confirms that there is a recent group A Streptococcus infection. So, again, if left untreated class, your strep throat can lead to complication. That is why, if you have strep throat class, dapat hindi siya ninyo binabaliwala. You should treat that one immediately. Consult with doctors so that it will be treated accordingly. So, first complication is your scarlet fever. A scarlet fever or your scarlatina is a punctuate exanthem. When we say exanthem, there is brush of the skin overlying a diffuse erythema that appears initially on the neck and chest. Your scarlet fever usually class happens after 2 days following a strep throat. It is caused by pyrogenic exotoxins, and one of the distinguishing characteristics of scarlet fever class is the appearance of strawberry-colored tongue. Again, distinguishing characteristic of scarlet fever is the appearance of strawberry-colored tongue. Another complication of your group is Streptococcus pyogenes is rheumatic fever. So rheumatic fever is thought to be due to immunologic cross-reaction between your streptococcal M protein and the heart muscle. Remember, as I said kanina, the M protein is the primary virulence factor of group A strep. So, your heart muscle also has M protein structure. So, sometimes there will be antigen-antibody complexes happen, lalo na if ever madalas ka na magkaroon ng strep throat. So, pabalik-balik na, your body, instead of attacking the M protein produced by Streptococcus pyogenes, it will now attack the M protein structures of the other structures sa imong body, like sa heart muscles as well as sa kidney, which cause glomerulonephritis. Okay, so let's go back to rheumatic fever. Rheumatic fever tends to occur 3 weeks after pharyngitis have subsided. It can result to the damage of heart valve, permanent damage of heart valves. So, for rheumatic fever, other symptoms includes arthritis, multiple joint pains, and appearance of nodules over bony surfaces. So, your post-streptococcal glomerulonephritis, again, this result from disposition of antigen-antibody complexes to the kidney naman. If etong rheumatic fever is sa heart muscle, yung streptococcal glomerulonephritis affects the kidney. So this is an inflammatory disease of the renal glomeruli. So it may occur class after pharyngitis or skin infection caused by group A strep. Now, let's go to the lower respiratory tract. So, for lower respiratory tract class, obviously, this is sterile. Okay? Kumbaga. So, dapat wala talagang organism dyan. If may organism dyan, it will really cause disease. Unlike your upper respiratory tract sa mouth, maraming microbial flora, mga normal flora. So, most likely, yung nagkakos ng disease sa upper respiratory tract are your normal flora in which, if ever, na-disturb siya. Okay? So now, let's go to lower respiratory tract infection. So the most common is your pneumonia. So your pneumonia is caused by either bacteria, protozoans, parasites, virus, and fungi. So for bacterial pneumonia, these are usually caused by your Streptococcus pneumoniae, Legionella, as well as your Mycoplasma pneumoniae. So, what is pneumonia? Pneumonia is a classic example of a disease characterized by anatomical diagnosis. It is defined as inflammatory condition of the lungs in which fluid fills the alveoli. Okay? The set of symptoms that we call pneumonia can be caused by a wide variety of different organisms, in the sense that the microorganisms need only to have appropriate characteristics to allow them to circumvent host defenses and to penetrate and survive in lower respiratory tract. So, pneumonia class in general, it is characterized by fever, productive cough, meaning there is a appearance of sputum, okay, acute chest pain, chills, shortness of breath. It is clinically diagnosed by abnormal chest sounds and chest radiographs. Pneumonia is often a secondary infection that follows a primary viral respiratory infection. So, as said, pneumonia may be caused by a gram-positive, gram-negative, mycoplasma, chlamydia, viruses, fungi, and protozoan. So, community-acquired pneumonia, bacterial pneumonia in general, is commonly caused by your Streptococcus pneumoniae. So, your Streptococcus pneumoniae is the most common cause of pneumonia in the world. Your Streptococcus pneumoniae is a gram-positive cocci, diplococci, that often appears in pairs. Okay? This is alpha hemolytic on blood agar. Kanina, si group A strep is beta hemolytic. Ngayon naman, si Streptococcus pneumoniae is alpha hemolytic. So, factors that favors the ability of pneumococci to cause disease are old age, underlying viral respiratory diseases, or possibly mga immune-compromised patients, or those chronic abuse alcohol and narcotic users. So for healthy people in the community, commonly inhale these type of organisms and other microorganisms into the respiratory tract without serious consequences because of the host defense present there. So normally naman class, pag hindi tayo immunocompromised, if ma-inhale man natin to si Streptococcus pneumoniae, Legionella, and Mycoplasma, if nagpa-function naman yung immune system, wala naman tayong sakit. So, those patients lang that are immunocompromised or those people that tend to destroy their immune system will have this type of infection. Because your Streptococcus pneumoniae is a frequent cause of pneumonia in older patients, the population is encouraged class to seek immunization, like your PPSV 23, which stimulates immunity to capsular polysaccharide 23, different strains of the bacterium. That is why class, for older individual, ang older population class, dapat magpa-pneumococcal vaccine talaga, especially now na may COVID. So, aside from the COVID vaccine, dapat yung mga matatanda, merong flu vaccine at saka ito, pneumococcal vaccine. Another causative agent of pneumonia is your Legionella. Legionella pneumophila, which is a causative agent of your Legionnaires' disease or your Punchak fever. Your Legionella pneumophilia is a gram-negative bacterium that has a range of shapes from coccus to filaments. So, several species or subtypes have been characterized, but Legionella pneumophilia is the most common isolated organism from an infection. So, these organisms class have the ability to survive and persist in natural habitats, and it is widely distributed in aqueous habitats like tap water, cooling waters, cooling towers, spa, ponds, and other fresh waters. So, this organism is resistant to chlorine. Okay? The bacterium can live in close association with free-living amoeba, like your acanthamoeba. It is released during aerosol formation and can be carried in long distance. So, transmissions for this type of infection include aerosols of Legionella species, that have been produced by vegetable misting devices in some supermarkets. So far, there is no reported cases of person-to-person transmission for Legionella. And lastly, your Mycoplasma pneumoniae. So your Mycoplasma pneumoniae is caused by is an etiologic agent that causes atypical pneumonia or your walking pneumonia. Your Mycoplasma pneumoniae is a tiny gram-negative bacterium, but it lacks cell wall. Okay? So your Mycoplasma pneumoniae has a gradual onset. Common symptoms, you have your headache, malaise, dry cough, sore throat, unless sometimes you have chest discomfort. So, your Mycoplasma pneumonia is transmitted by aerosol droplets among people confined in close living quarters, especially families, students, and those that are in military. So, lack of acute illness in most patients has given the name walking pneumonia. Again, in the exam, if asked what is the causative agent of walking pneumonia, your answer should be Mycoplasma pneumoniae. So your Mycoplasma pneumoniae class infection is diagnosed using culture, serology, or nucleic acid amplification testing. So usually, these CDC guidelines includes PCR as the primary laboratory procedure for Mycoplasma pneumoniae infection. So, since this is bacterial type of infection, antibiotic treatments are available. So, for Streptococcus pneumoniae, you have their cefotaxime, ceftriaxone, with or without vancomycin. For Legionella, you have fluoroquinolone, azithromycin, and clarithromycin. And for Mycoplasma, you have your doxycycline. But there is an issue on treating Mycoplasma class because, again, it lacks cell structure like your cell wall. So, hindi pwedeng bigyan yung mga may atypical pneumonia na mga cell wall inhibitory drugs. Another common disease that affects lower respiratory tract is your tuberculosis. So, your tuberculosis is caused by Mycobacterium tuberculosis. Okay? Mycobacterium tuberculosis is a slow-growing, acid-fast, gram-positive to gram-variable bacillus. And sometimes in some textbooks, these are referred to tubercle bacillus. So if you notice here, it's red because it's acid-fast. So review acid-fast staining. Tuberculosis is particularly good illustration of ecological balance between the host and the parasite in infection. A host is not usually aware class of tuberculosis pathogen that invades the body because these are defeated by your immune system all the time, 90%. If the immune defenses class fail, the host becomes very much aware of the resulting disease. So, TB or tuberculosis is a chronic granulomatous infection which is transmitted through inhalation. That is why through airborne siya. Okay? Inhalation of infected droplet of TB nuclei by means of coughing, which is the most obvious symptoms of the TB infection, sneezing, or even speaking. So, common signs and symptoms of tuberculosis, you have the low-grade fever, night sweats, fatigue, anorexia, and weight loss. So, clinical diagnosis of primary TB is usually limited to the detection of tuberculin test. This one here in the picture. So, using purified derivative protein. The injection is done just like a skin test, is done intradermally into the forearm to produce an immediate small bleb. I think you already know how to perform this one since you are nursing students. After 48 to 72 hours class, the site is observed for a red wheal called induration, which is measured and interpreted as positive or negative according to the size. So you have there 3 categories. So for category 1, category 2, and category 3. Usually, healthcare workers, class positive talaga yan for category 1 because we are exposed to patients. Aside from normal TB class, you also have MDR-TB and XDR-TB. So what are these MDR-TB and XDR-TB? Your MDR-TB or multi-drug resistant TB and your extensively drug-resistant TB develops when the patient class fails to take all the prescribed drugs for the TB treatment. So what are those TB treatment drugs? You have there your isoniazid, rifampin, pyrazinamide, ethambutol, or streptomycin. If ever class hindi yan tinitake ng patient religiously, it may develop to MDR or XDR-TB. So what's the difference between MDR-TB and your XDR-TB? So your MDR-TB is defined as without previous history of the TB disease and resistant to at least 2 anti-TB drugs. So resistant siya either to isoniazid or rifampin. Your XDR-TB naman is defined as resistance to isoniazid, rifampin, fluoroquinolones, and at least one of the 3 parenteral drugs common for anti-TB like your aminoglycosides. So here, class explains the concept of the pathogenesis of the TB. So you have 5 steps. On the first step, your tubercle bacilli reach to the alveoli of the lungs, diba, are ingested by a macrophage. So this is your TB bacilli. Primary response of your alveolar macrophage, it will ingest. So infection is present, but there will be no symptoms of the disease. That is why kanina, for healthy lang, wala talagang symptoms mangyayari because it will be just ingested by your alveolar macrophage, which is part of your immune response. Second, the tubercle bacilli multiply in the macrophage and causes chemotactic response that brings additional macrophage and other defensive cells to the area. This forms surrounding layer and in turn an early tubercle. So most of the surrounding macrophage are not successful in destroying bacteria but release enzymes and cytokines that causes lung damaging inflammation. On the third step, after few weeks, the disease symptoms appear as many of the macrophages die, releasing now your tubercle bacilli, forming a caseous center in the tubercle. That's one. The aerobic tubercle bacilli do not grow well in this location because it will require oxygen. So, however, many remain dormant or it becomes a latent TB and serve as the basis for later reactivation of the disease. The disease may be arrested at this stage and the lesions become calcified. Reactivation class only occurs when there is alteration of the cellular immune responses. So, here on this process class 3 and 4 process, this will now be clinically diagnosed on your chest X-ray film. You will see gone complexes. If ever the TB class reactivate in some individuals, the disease symptoms appear as mature tubercle is formed. So, the disease progresses as the caseous center enlarges in the process called liquefaction. The caseous center now enlarges and forms an air-filled tuberculous cavity in which the aerobic bacilli multiply outside the macrophage. And lastly, the liquefaction continues until the tubercle or that gone complex has rupture, allowing your TB bacilli to spill into a bronchiole and thus disseminated throughout the lungs and then circulatory and lymphatic system. That is why you also have miliary TB, which is also known as extrapulmonary TB. Another bacterial disease that affects lower respiratory tract is your pertussis or your whooping cough, which is caused by Bordetella pertussis. So whooping cough is a highly contagious acute bacterial childhood infection which is caused by Bordetella pertussis, which is a small encapsulated non-motile gram-negative coccobacillus that produces endotoxin and exotoxin. So, this disease has two distinct phases called catarrhal phase and paroxysmal phase. Which are followed by a long recovery or convalescent phase, during in which a patient is particularly susceptible to other infection. After incubation period of 3 to 21 days, the catarrhal stage or the prodromal stage begins when a bacteria present in the respiratory tract cause what appears to be a cold symptoms, most notably a runny nose. So during this type of stage class, the patient will experience rather cold symptoms and runny nose. So this prodromal or catarrhal stage will last 1 to 2 weeks. After 2 weeks, the disease worsens into a second stage called paroxysmal stage, which is characterized by severe and uncontrollable coughing, a paroxysm that can be thought as convulsive attack. That is why it got its name, because of the disease comes from a whooping sound when a patient makes he or she tries to grab a breath between uncontrollable coughing. So on this stage class, you will hear a whooping sound. That is why it's called as whooping cough. So as in any disease, convalescent phase is the time when the number of bacteria are decreasing and no longer cause ongoing symptoms. So far, pertussis or whooping cough infection can be treated using antibiotics like azithromycin. And this can be prevented class using, again, a vaccine, a cellular vaccine, which is incorporated in your DTaP vaccine. So, you have the DTaP vaccine, which is given sa mga bata. For the diagnosis of this infection, you have culture and microscopy. Aside from bacterial infection class, fungal infections also causes, fungal organism also causes lower respiratory tract infection. Common are those three. You have your Coccidioides immitis, Histoplasma capsulatum, and your Pneumocystis jirovecii. So let's start with Coccidioides immitis, which is the causative agent of your coccidioidomycosis. So your Coccidioides immitis is a dimorphic fungi which exists as molds in soil and yeast when exposed in a body temperature. So in tissues class, it appears as spherical yeast called spherules that surrounds endospore formation. So your C. immitis arthrospores have potential use as bioterrorism agent. So since it forms arthrospores, the mode of transmission is usually inhalation of arthrospores. So the infection start as a respiratory infection with fever, chills, cough, rarely pain, and it also disseminates. Okay, so this infection disseminates, which includes lung lesions, abscess throughout the body, especially in the subcutaneous tissues, skin, bone, and central nervous system. So this can be treated using fluconazole. Your Histoplasma capsulatum is the causative agent of your histoplasmosis. Histoplasma capsulatum class is also a dimorphic fungi. Again, it grows molds in soil and yeast inside animal hosts. Always take note class that dimorphic fungi, dalawa talaga yung appearance ng fungi. Mold siya pag outside, pag inside siya sa host at 37 degrees Celsius, it will form yeast. Okay, pag outside, molds, filamentous fungi. Histoplasmosis class, by the way, is a systemic mycosis of varying severity ranging from asymptomatic to acute infection. Primary lesion is usually in the lungs. Acute diseases involves malaise, fever, chills, headache, myalgia, chest pains, and non-productive cough. So when we say non-productive cough, no sputum is produced. So your histoplasmosis is the most common systemic fungal infection associated with AIDS patients. So this can be treated using itraconazole. Another fungal infection is your Pneumocystis carinii pneumonia or your PCP. Your PCP is caused by Pneumocystis jirovecii. This organism has both protozoal and fungal properties. It was classified as protozoan for many years but is currently classified as non-filamentous fungus. Your PCP class is an acute to subacute pulmonary disease found in malnourished, chronically ill children, premature infants, and immunosuppressed patients like those AIDS patients. Patients may suffer fever, difficulty in breathing, rapid breathing, dry cough, cyanosis, pulmonary infiltration of the alveoli with frothy exudates. So PCP is usually fatal if left untreated among immunosuppressed patients. That is why it is the most common contributory cause of death in AIDS patients because these patients are immunocompromised. So pneumocystis causes asymptomatic infections naman in immunocompetent people. So pag healthy yung tao, hindi naman siya makaka-experience ng ganitong type of infection kasi mamamatay siya with the help of your immune cells. So for treatment of PCV, antifungal is given lalo na to the AIDS patient to prevent this type of infection. So picture here are the life cycle of the organisms I mentioned in the previous slide. So here, your coccidioidomycosis, once inside the body, it forms spherules, but outside, it's just an arthrospores. Okay, here's your histoplasmosis. Again, inside it's yeast, outside it's filamentous fungi. And ito naman yung PCP or your Pneumocystis carinii pneumonia. Now let's go to bacterial and fungal infections that affects the oral region and your gastrointestinal tract. Number 1 is your bacterial gastritis or gastric ulcer. Your bacterial gastritis and gastric ulcer is caused by a bacterium known as Helicobacter pylori. So gastritis is experienced as sharp or burning pain emanating from the abdomen. Gastric or peptic ulcers class are actual lesions in the mucosa of the stomach or in the upper portion of the small intestine causing duodenal ulcer. Severe ulcers can be accompanied by bloody stools, vomiting, or both. The symptoms are often worse at night after eating or under condition of psychological stress. So usually, pag ma-stress ka lalo na ngayon, sa panahon ngayon, common ang gastritis. Bacterial gastritis is the second most common cancer in the world. Okay? And ample evidence suggests that long-term infection with this Helicobacter pylori is the major contributing factor why there is stomach cancer. Helicobacter pylori, by the way, is a curved microaerophilic, caphenophilic, or gram-negative bacillus that is found on the mucose-secreting epithelial cells of the stomach. The mode of transmission of these bacteriums remains mystery, but studies have shown that the pathogen is present in a large proportion of the human population. So your H. pylori is probably transmitted from person to person by oral, or fecal-oral route. It seems to be acquired early in life and carried asymptomatically until the activities begin to damage the digestive mucosa. So, the common virulence factors of Helicobacter pylori is adenosine and urease. So, that is why it lives on the stomach because of the enzyme urease. It converts enzymes to ammonia. Okay? Adenosine is used for adhesion. So, the most reliable diagnostic test requires a biopsy of the tissue and culture of the organism. An interesting diagnostic approach is the urea breath test, in which the patient swallows radioactively labeled urea, and if that test is positive, a CO2 labeled with radioactivity can be detected in the breath within 30 minutes. This test is commonly useful for determining the effectiveness of chemotherapy because a positive test is an indication of live H. pylori. There are also diagnostic tests that include stool examination that detects antigen of H. pylori, which is suitable for follow-up tests following therapy. So here is the picture of how H. pylori causes disease. So again, the stomach mucosa contains cells that secrete gastric juice containing proteolytic enzyme and hydrochloric acids that activate these enzymes. Other specialized cells produce layer of mucus that protects the stomach from the digestion. So these are the epithelial cell that protects the stomach. If this defense is disrupted, like this one is disrupted, the inflammation of the stomach or gastritis results. The inflammation can then progress into ulcerated area through an interesting adaptation. H. pylori can grow in a highly acidic environment of the stomach, which is lethal for most microorganisms. And one thing to note, only H. pylori class can live in your stomach area, no other microorganism. So H. pylori can grow in a high acidic environment of the stomach, which is lethal for most microorganisms. And this microorganism class produces large amount of an especially efficient urease, as I said, as one of their major virulence factor, in which this enzyme converts urea to alkaline compound ammonia, resulting into locally high pH in the area of the growth. So this picture here, show how does microorganism, your H. pylori, cause gastric ulcer. Okay? Since your bacteria has an enzyme urease, it can leave the acidic nature of the stomach. So once it penetrates class to the epithelial lining of the stomach, it releases enzymes and proteins class that will now destroy the lining epithelium of the stomach. Once the lining epithelium of the stomach is destroyed, obviously the acidity, your HCl class, will now penetrate to the basement membrane and connective tissue of your stomach, forming ulcerations. Okay? So, pag ma-expose na tong connective tissue clot, it will now cause ulceration. Muna nang meron ka ng peptic ulcer because of the HCl produced by your gastric juice. Here is another bacterial infection that causes bacterial infection in your gastrointestinal tract is acute diarrhea. So diarrhea class is usually defined as 3 or more loose stool in 24-hour period. So this is common in developing countries with high mortality rate is not only the issue. So, usually, diarrhea is accompanied by fever, abdominal pain, or cramping, nausea, vomiting, and dehydration. So, acute diarrhea may be caused by either bacteria, protozoans, or sometimes viral. Okay? So, let's start with salmonella. So, your salmonella bacteria, these are named from the discoverer Daniel Salmon. These are gram-negative facultative anaerobic bacteria, a non-endospore forming rods. Their normal habitat is in the intestinal tract of the human and many animals. All Salmonella class are considered pathogenic to some degree, causing salmonellosis or Salmonella gastroenteritis. So, salmonellosis usually results to sudden onset of headache, abdominal pain, diarrhea, nausea, and sometimes vomiting. And for salmonellosis class, dehydration may be severe. Sometimes, if left untreated, salmonellosis may develop into septicemia or localized infection in any tissue of the body. So the transmission includes ingestion of contaminated food like eggs, unpasteurized milk, meat, poultry products, raw fruits and vegetables, or fecal oral transmission from a person to person, food handlers, or contaminated water supplies. Aside from salmonellosis class, your salmonella also has another serotype that is responsible for typhoid fever. Okay? So unlike the ordinary salmonella that causes salmonellosis, your salmonella typhi, which is the causative agent of your typhoid fever, is a pathogen not found in animals. It is spread only in the feces of other human. Typhoid fever, by the way, is a systematic bacterial disease with a fever, severe headache, malaise, anorexia, rash on the trunk in about 25% of the patient, and non-productive cough. Some people are carriers of this type of infection, which sheds the pathogen in their feces or urine. So, the same transmission, fecal-oral route, as well as oyster, harvested from a contaminated water with feces, fecally contaminated fruits, and raw vegetables. So, for Shigella causes shigellosis, or also known as your bacillary dysentery. Bacillary dysentery is different from your amoebic dysentery because your amoebic dysentery is caused by protozoan. Okay, primarily your Entamoeba histolytica. But for your bacillary dysentery, these are caused by Shigella species. So, you have 4 species of pathogenic Shigella. You have Shigella sonnei, Shigella dysenteriae, Shigella flexneri, and Shigella boidae. These bacteria are residents only of the intestinal tract of human, apes, and monkeys. These are closely related to pathogenic E. coli. They are non-motile, gram-negative rods, and people become infected through direct or indirect fecal-oral transmission from patients or carrier. So, fecally contaminated hands and fingernails, or fecally contaminated food, milk, and drinking waters. Flies can also be a factor, mechanical vector for this type of infection. Next is your STEC-associated E. coli or your enterohemorrhagic E. coli diarrhea. So, the disease consists of hemorrhagic, watery diarrhea with abdominal cramping. So, usually, the patients have no fever or only slight fever. And the patient develop hemolytic uremic syndrome with anemia, low platelet count, and kidney failure. Your STEC class is caused by your E. coli 0157H7. Again, STEC is caused by your E. coli 0157H7, a serotype that possesses a soluble antigen designated as 0157 and a flagellar antigen designated as H7. So the transmission is obviously fecal-oral route. So In humans, the Shiga toxin produced by EHEC cause only self-limiting diarrhea, but 6% of infected people produce inflammation of the colon, resulting to hemorrhagic colitis. So one dangerous complication of STEC class is hemolytic uremic syndrome, which is characterized by blood in the urine. So again, if asked in the exam, the causative agent of hemolytic uremic syndrome for bacteria, it is the STEC or the EHEC strain. So your HUS or hemolytic uremic syndrome is characterized by blood in the urine leading to kidney failure. So it affects kidney when the toxin reaches the kidney. So management usually includes intravenous rehydration and careful monitoring of serum electrolytes. Aside from EHEC strain of E. coli, you have your other strain of E. coli. You also have your ETEC strain, which is the causative agent of your traveler's diarrhea. This disease is a watery diarrhea with or without mucus or blood in the stool. It also consists of vomiting and abdominal cramping. So dehydration and low-grade fever also may occur for this type of infection. So again, mode of transmission, fecal-oral route. So once contracted, the best treatment is the usual oral rehydration recommended for all diarrhea. In severe cases, antimicrobial drugs may be necessary. For Campylobacter gastritis, Campylobacter gastritis or Campylobacter enteritis is an acute bacterial disease ranging from asymptomatic to severe infection with diarrhea, nausea, vomiting, fever, malaise, and abdominal pain. The disease is usually self-limiting that lasts 2 to 5 days. Stool may contain gross or occult blood, mucus, and WBCs. So, Campylobacter gastroenteritis is caused by Campylobacter species, particularly the most common, your Campylobacter jejuni, which are gram-negative, microaerophilic, and spirally curved bacteria. Okay? One complication for Campylobacter gastroenteritis is your Guillain-Barré syndrome, which is a temporary paralysis. Lastly, you have their cholera, which is caused by Vibrio cholerae. Cholera is an acute bacterial diarrheal disease with profuse watery stool. So, most common clinical feature for cholera is watery stool. So, in some textbook, it is described as rice watery stool. Yung parang sa sinaing, parang yung nagpapara sa sinaing class. So, if untreated, circulatory collapse, renal failure, and death may occur. So the etiologic agents for your cholera is your Vibrio cholerae serogroup 01. These are curved rods, gram-negative rods that secretes enterotoxin, in which that toxins affect the cells in the intestinal tract. By the way, the toxin is called as choleragen. Again, toxin released by Vibrio cholerae is choleragen. The treatments often include the use of antibiotics like doxycycline, but the most effective therapy is intravenous replacement of the lost fluids and electrolytes. Kadalasan, namamatay yung mga patient with cholera dahil dehydration. Pero may treatment naman for cholera. So for oral region, you have their acute necrotizing ulcerative gingivitis, which is caused by your Fusobacterium nucleatum, Treponema vicentii, which is a spirochete, and some anaerobic organism. So acute necrotizing ulcerative gingivitis is also known as Vincent's angina or trench mouth. So trench mouth is an example of synergistic infection. So here is the picture of acute necrotizing ulcerative gingivitis. So in order to avoid this one, good oral hygiene is a must. Fortunately, trench mouth is thought to be non-contagious naman. You also have oral thrush, which is caused by Candida albicans. So, oral thrush clinical features includes white creamy patches that occurs in tongue, your mucous membranes, and the corners of the mouth. Usually, by the way, thrush is a yeast infection of the oral cavity, and it's common in infants, elderly patients, and immunosuppressed individuals. Kasi opportunistic infection yung mga Candida albicans. So, treatment includes fluconazole, cotrimazole, and nystatin, and these are all antifungal agents. Now, let's go to bacterial and fungal infections of the reproductive system. So, let's start with the genital discharges. Bacterial disease that causes genital discharges. You have the most common, gonorrhea and chlamydia. So, let's start with gonorrhea. Gonorrhea has been known as sexually transmitted disease since ancient times. It was named by Greek physician Claudius Galen, who thought it was caused by an excess flow of semen. Gonorrhea is caused by your Neisseria gonorrhoeae, which is also known as gonococcus, which is a gram-negative cocci in pairs. The transmission usually is via direct mucous membrane to mucous membrane contact, usually sexual contact, adult to child may indicate sexual abuse, or mother to neonate during birth. The clinical features of gonorrhea in male, usually infection of the urethra elicits urethritis, painful urination, and yellowish discharge, although a relatively large number of cases are asymptomatic. In most cases, male infection is limited to distal urogenital tract, but it can occasionally spread from urethra to prostate gland and epididymis. For female naman class, it is likely that both the urinary and genital tracts will be infected during sexual intercourse. A mucopurulent containing mucus and pus or bloody discharge occurs in or about half the case, along with painful urination if the urethra is affected. So for female, the major complications occurs when the infection ascends from vagina and cervix to higher reproductive structures such as uterus and fallopian tubes, causing salpingitis or pulmonary phylvic inflammatory diseases. So far, no vaccine is available for gonorrhea. Using condoms still is an effective way to avoid transmission of this type of infection and other discharges diseases. Although there are reported cases already of resistant to penicillin gonococcus because the most common treatment for gonorrhea is penicillin, but there are resistant strains for gonococcus. So the CDC class has recently changed its overall recommendation for treatment of gonorrhea worldwide and advises now the usage of ceftriaxone plus azithromycin or doxycycline. But before, it's penicillin lang. But now, it's a combination drugs because of the resistant strain of gonococcus. Chlamydia, on the other hand, is caused by Chlamydia trachomatis, which is considered to be the most common sexually transmitted pathogen. Chlamydia trachomatis is a very small gram-negative bacterium which lives inside the host cell as obligate intracellular parasite. All chlamydia species alternate between two distinct stages. Take note, that the infectious form of chlamydia is called elementary bodies. Again, infectious form of chlamydia is elementary bodies, while reproductive forms are called reticulate bodies. Reproductive form, reticulate bodies. Transmissions occurs via direct sexual contact or mother to neonate during birth. So, there are different serovars of Chlamydia trachomatis causes different diseases. Only serovars D and K are the major cause of the non-gonococcal urethritis and epididymitis in men, and cervicitis, urethritis, and endometritis in women, causing mucopurulent discharge, urethral itching, and burning on urination. It may also cause infertility and proctitis in men. So if you notice here, for treatment of the two organisms, the CDC recommends annual screening of the young women for asymptomatic patients with chlamydia. It is also recommended that older women with some risk factors like new sexual partner, for instance, should be screened. Treatment is usually with doxycycline or azithromycin. Always take note that co-infection with gonorrhea should be assumed and treated similarly. Many patients become reinfected soon after the treatment. Therefore, the recommendation is that patient should be rechecked for chlamydia infection 3 to 4 months after treatment. Next infection is syphilis. Syphilis is caused by a gram-negative spirochete known as Treponema pallidum. Treponema pallidum is a thin and tightly coiled spirochete. It stains poorly with using ordinary stain. That is why it uses silver staining and direct fluorescent stain. T. pallidum has no obvious virulence factors such as toxins class, but it produces several lipoproteins that induce inflammatory immune response, which is apparently causes the tissue destruction of the disease. Syphilis is a transmitted by sexual contact of all kinds via syphilitic infections of genital or body parts. The incubation period is usually 3 weeks, but it can range 2 weeks to several months. So, the disease progresses through several stages. So, you have primary stage, secondary, latent stage, and tertiary stage. So, we'll discuss this on the next slide. So, diagnosis of syphilis is complex because of each stage of the disease. It has unique requirements. So, the test falls into 3 general groups: visual microscopic infections, non-treponemal serologic tests, and treponemal serologic tests from lesions when these are present. If screening is positive, the results are confirmed by treponemal tests. So the treatment of choice is benzathine penicillin, a long-acting formulation that remains effective in the body for about 2 weeks. For penicillin, sensitive people naman, several antibiotics are given like azithromycin, doxycycline, and tetracycline. So as mentioned kanina, there are 4 stages of Treponema pallidum or syphilis. Your primary stage, these are characterized by appearance of chancre, and the chancre is usually described as hard chancre. The chancre is painless and an exudate of serum forms in the center. This fluid is highly infectious, and examination with dark field microscopy shows many spirochetes. In a couple of weeks, these lesions class disappears. None of these symptoms causes any distress. In fact, many women are entirely unaware of the chancre, which is often on the cervix. In men, the chancre sometimes forms in the urethra and isn't visible. During this stage, the bacteria enter the bloodstream and lymphatic system, which distribute them widely in the body. On secondary stage, several weeks after the primary stage, the exact length of time varies and may overlap from the primary stage. The disease enters now into the secondary stage, which are characterized by skin rashes. If the primary stage characteristics is hard chancre, the secondary stage class naman is skin rashes. The rash class is widely distributed on the skin and mucous membranes and especially visible on palms and soles. At this stage naman class, the lesion of the rash contains many spirochetes and very infectious. Transmission from sexual contacts occurs during primary and secondary stage. Secondary syphilis is subtle disease, and at least half of the patients diagnosed with this stage can recall no lesions at all. Symptoms usually resolve within 3 months. After secondary stage, latent stage may occur. The symptoms from the secondary stage will go away with or without treatment, and the disease enters to a latent period. So during this period, there are no symptoms. After 2 to 4 years of latency, the disease is not normally infectious except for transmission to mother to fetus. The majority of the cases don't progress beyond the latent stage even without treatment. In this stage, diagnosis can only be made using serologic testing. And lastly, because of the symptoms of the primary and secondary stage aren't disabling, people may enter the latent period without having received medical attention. And in up 25% of untreated cases, the disease reappears in a tertiary stage. This stage occurs only after interval of many years from the onset of the latent stage. Tertiary or late stage of syphilis can be classified generally by affected tissues or type of lesion. So, gummatous syphilis is characterized by presence of gummas, which are form of progressive inflammation that appears as rubber masses of tissue in various organs. Other complications include cardiovascular abnormalities. That is why you have cardiovascular syphilis, which results to weakening of the aorta. And you can also have central nervous disease, which is your neurosyphilis. So for neurosyphilis, patients can suffer from personality changes and other signs of dementia, seizures, loss of coordination, of voluntary movement, partial paralysis, and even loss of sight, hearing, loss of bowel, and bladder control. So again, as a review, for primary syphilis, you will see hard chancre. For secondary syphilis, you will see rashes. For latent syphilis, no symptoms at all. So the only way to detect whether the patient is on latent syphilis stage is through serologic test. And on tertiary syphilis, the patient, you will see gummas of the skin. So gummas on different site of the body. So for tertiary syphilis, it can also cause cardiovascular syphilis and neurosyphilis. Vaginitis is also one of the reproductive cyst infections. Yeast vaginitis is caused by Candida albicans. So what is vaginitis, by the way? Vaginitis is an inflammation of the vagina, a condition characterized by some degree of vaginal itching, depending on the etiologic agent. So symptoms may also include burning and sometimes a discharge, which may take different form as well. So vaginosis is similar but does not include significant inflammation. So for yeast vaginitis, it is commonly caused by Candida albicans, which is a dimorphic fungus that is normal biota in human. The vaginal condition causes vulvovaginal candidiasis. So the yeast is easily detected using a wet prep or a gram stain of a material obtained from pelvic examination. So discharges, from these discharges, the laboratory will do wet preparations or gram stain. So here, this is an example of a gram stain. A present of pseudohyphae in the smear. The pseudohyphae here is this one. Kaninga portion. There is your conidia. That's the conidia. This one. These are epithelial cell. Kani sila is the yeast. kanang dark portion. But here is the pseudohyphae. The presence of pseudohyphae in the smear is a clear indication that yeast is growing rapidly and causes yeast infection. So far, no vaccine is available for Candida albicans. Topical and oral azoles are used to treat vaginal candidiasis, and many of them are available over the counter. Now let's go to bacterial infection of the cardiovascular and lymphatic system. To start with, you have the rickettsial or the Ehrlichial diseases. So, rickettsial and Ehrlichial diseases, you have their Ehrlichiosis and anaplasmosis. So, what the difference? The two, human monocytotropic Ehrlichiosis, your HME is caused by Ehrlichia species, particularly your Ehrlichia chafensis, which is a gram-negative rickettsia-like obligate intracellular bacterium. Your Ehrlichiosis is a tick-borne disease, common among vector like ticks, particularly your Lone Star tick. Similar disease to your Ehrlichiosis, you have your anaplasmosis or your human granulocytic anaplasmosis, which is caused by an organism known as Anaplasma. These are still tick-borne diseases caused by exodic ticks, the same genus vector as Lyme disease and babiosis. So for both Ehrlichiosis and anaplasmosis, the patient's class may suffer flu-like symptoms with high fever and headache, and cases of these two infections are both widespread and sometimes geographically overlap. So once either the disease is suspected, diagnosis is usually by indirect fluorescence and polymerase chain reaction. So therapy with antibiotics like doxycycline or tetracycline is effective for this type of infection. Typhus fever. Typhus fever is caused by Rickettsia prowazekii, which is carried by human body louse, Pedicellus humanus corporis. By the way, this is your Exodus ticks. This is your body louse, body lice, pubic lice, and head lice. So, the pathogen grows on the intestinal tract of the louse and is excreted by it. It is transmitted when the feces of the louse are rubbed into the wound when the bitten host scratches the bite. Typhus fever produces high and prolonged fever and lasts 2 weeks. Usually, a stupor and a rash of a small red spots caused by subcutaneous hemorrhaging are characteristics of this type of infection. So, tetracycline and chloramphenicol are usually effective against typhus fever. But eliminating condition in which disease flourishes is more important. Endemic murine typhus is transmitted by a rat flea or Cynomyces, which is the pathogen responsible is your Rickettsia typhi, a common inhabitant of the rat. Endemic murine typhus is clinically indistinguishable from typhus fever. So, tetracycline and chloramphenicol are effective treatment for endemic murine typhus, as well as rat control is the best preventive measure for this type of infection. And lastly, spotted fever, tick-borne typhus or Rocky Mountain spotted fever is probably the best known rickettsial disease. It is caused by Rickettsia rickettsii. This rickettsia is a parasite of ticks. It can be caused by dermacenter ticks. In West, they call the dermacenter ticks as wood tick, while in the East, they call it as dog. For the East portion, the dermacenter ticks are usually the wood ticks, while for the West naman class are the dog ticks, ang responsible vector. So, usually, the infection pass from one generation of ticks to another through their eggs, a mechanism called trans-ovarian passage. After a week of tick bites, a macular rash develop that is sometimes mistaken for measles. However, it often appears on palms and soles where viral rashes do not appear. The rash is accompanied by fever, headaches. So, serological tests don't become positive until the late onset of the diseases. So, diagnosis before typical rash appears is difficult because of the symptoms vary widely. So, antibiotics like tetracycline and chloramphenicol are still effective in treating Rocky Mountain spotted fever. So far, no vaccine is available for this type of infection. Next infection is your Lyme disease or caused by Borrelia burgdorferi. Lyme disease is a slow-acting but often evolves into a slowly progressive syndrome that mimics neuromuscular and rheumatoid conditions. So on early symptoms class, for Lyme disease, you will see rash at the site where there is a tick bite. Lyme disease, by the way, is still vector-borne diseases. Same with your Ehrlichial and rickettsial disease. Okay, the lesions class is called erythema migrans because it looks like bullseye with raised erythematous ring that gradually spreads outward and a pale central region. Other symptoms include fever, headache, stiff neck, dizziness, and if not treated class or if treated too late, the disease can advance into the second stage during which now involves cardiac and neurologic symptoms. So again, Lyme disease is caused by Borrelia burgdorferi, which is an unusual spirochetes that is large, and it is different from your Treponema pallidum because these are loose coil spirochetes. So these are loose coil spirochetes unlike your Treponema pallidum. So Borrelia burgdorferi are transmitted primarily by hard ticks of the genus Ixodes. The same with your The same with your Ehrlichiosis. So, most suggestive diagnoses are ring-shaped lesion isolations of spirochetes from patients and serologic testing with ELISA methods. So, for treatment naman class for Lyme disease, early and prolonged treatment with doxycycline and amoxicillin is effective, and other antibiotics like ceftriaxone, penicillin are used for late Lyme disease therapy. Plague is also one of the diseases common for lymphatic infections. Plague is an acute, which is often severe zoonosis. Initial signs and symptoms may include fever, chills, malaise, myalgia, nausea, prostration, sore throat, and headache. So the etiologic agent of plague is Yersinia pestis, which is a non-motile bipolar staining gram-negative Coccobacillus. So these are the appearance of your plague under microscope. They are bipolar staining. That is why they are some textbooks they are referred to close safety pin appearance. Reserva of your Yersinia pestis includes wild rodents and their fleas, rarely rabbits, wild carnivores, and domestic cat. Transmission is usually via cases. The inguinal groin area, lymph nodes are involved. Flea bite, from rodents to flea, then to human. And also transmission may also result of handling tissues of infected rodents, rabbits, and other animals, as well as droplet transmission for pneumonic plague. There are three possible manifestation of plague. You have the bubonic plague, which is swollen, inflamed, this one, like in the picture. Swollen, inflamed, and tender lymph nodes or buboes are formed. Usually, the lymph nodes affected are those receiving drainage from the site of the bite of infected area. You also have pneumonic plague, which are highly communicable, which involves the lungs. And you have the systemic plague, in which there is a presence of bacteria in the blood that can cause septicemia. So once the organism is present in the blood, it can cause subcutaneous hemorrhage and purpura and may degenerate into necrosis and gangrene, which will now lead to septic shock, meningitis, and even death. Tularemia. Tularemia is also known as rabbit fever, which is an acute zoonosis with a variety of clinical manifestation depending on the portal of entry of the pathogen into the body. So your tularemia class is most often present as skin ulcer, like this, or unregional lymphadenitis. Ingestion of the pathogen also results to pharyngitis, abdominal pain, diarrhea, and vomiting. So the causative agent of your tularemia is your Francisella tularensis, a facultative intracellular gram-negative bacterium. It is a zoonotic disease assorted mammals endemic to northern hemisphere. The transmission usually via tick bites or ingestion of contaminated drinking water. Entry of organisms into the wound while skinning infected individuals, inhalation of dust also, or animal bites. There are no reported cases for person-to-person transmission for this type of infection. Because of the intracellular persistence of Francisella tularensis can lead to relapses, antimicrobial therapy must not be discontinued prematurely. So protection is available in the form of live attenuated vaccine for high-risk individuals like laboratory workers and other occupationally exposed personnel. So for these personnel, they should wear protective equipment, protective personal equipments like gloves, masks, and eyewears. Lastly, let's now discuss bacterial and fungal infections that affect central nervous system. So you have there meningitis. So meningitis is caused by either bacterial, fungal, protozoal, and viral. So for this discussion, we'll talk about bacterial and fungal diseases. So the initial symptoms class of meningitis are not especially alarming, and a triad of fever, headache, and stiff neck. So again, take note class that the triad of symptoms for meningitis are fever, headache, and stiff neck. Okay? Nausea and vomiting are often follows. Eventually, meningitis class may progress to convulsion and trauma and coma. The mortality rate varies with pathogen but is generally high for infectious diseases today. So meningitis can caused by different pathogens including bacteria, fungi, protozoans, and viruses as mentioned. So let's start with Haemophilus influenzae meningitis. So your Haemophilus influenzae meningitis is caused by your Haemophilus influenzae, which is again an aerobic gram-negative bacterium that is common member of the normal throat microbiota. So occasionally, it enters the bloodstream causing several invasive diseases. So Haemophilus influenzae type B primarily causes meningitis. Again, H. influenzae type B causes meningitis mostly in children under the age of 4. So when antibody protection provided by the mother weakens, the incidence of the decreasing infection because the the Hep vaccine, which which was introduced in 1988. Again, H. influenza meningitis is common among children. Well, take note for that one. And prevention is Hep vaccine or Haemophilus influenzae type B vaccine. Next is meningococcal meningitis, which is caused by Neisseria meningitidis, a meningococcus. This is an aerobic gram-negative bacterium with polysaccharide capsule that is important to its virulent. Okay? So, like your Haemophilus type B, and your pneumococcus, it is frequently present in the nose and throat of the carriers without causing the disease of infection. The symptoms of meningococcal meningitis are mostly caused by endotoxin that is produced rapidly and capable of causing death within just few hours. So the most clinical symptoms for meningococcal meningitis class is rash that does not fade when pressed. So a case of meningococcal meningitis typically begins with a throat infection leading to bacteremia and eventually meningitis. So this is common among children under 2 years. For pneumococcal meningitis, these are caused by Streptococcus pneumoniae, again, which is a gram-positive diplococci. It's a leading cause of bacterial meningitis. Most cases of pneumococcal meningitis occurs among children between 1 month to 4 years. So, in order to be protected, vaccine is available for this type of infection. Lastly, your listeriosis for bacterial disease. Listeriosis is caused by Listeria monocytogenes, which is a gram-positive bacterium which ranges from cocobacilli to long filaments in palisades formation. So, your Listeria organism grow inside the host cell and can move directly from one infected host to an adjacent healthy cell. So, the disease appears in two basic forms in adults as an infection in fetus and newborn. In adults, it's usually mild and symptomless disease. But for newborn, okay, it has severe implications. Listeria monocytogenes is especially dangerous when it infects a pregnant woman because this organism class causes miscarriage. So the pregnant woman usually suffers flu-like symptoms. So the fetus, however, can be infected by a placenta, often resulting to abortion or stillborn infants. So diagnosis for listeriosis in humans depend on isolating and culturing the pathogen, usually from blood or cerebrospinal fluid, and the treatment of choice is usually penicillin G. For fungal-associated meningitis, the most common is your cryptococcosis. Cryptococcosis is caused by fungus Cryptococcus neoformans, which is a encapsulated yeast. Okay, so here in the picture, it has a spherical to ovoid shape with small contracted buds and a large capsule that is important in pathogenesis. So the disease may be contracted by inhaling dried infected pigeon or chicken droppings. The disease begins as lung infection and may spread to the brain and meninges. So this is common class among immunosuppressed individuals, particularly the AIDS patients, because these are the most susceptible individual. So for cryptococcosis class, headache is the most common symptoms, but nausea and neck stiffness are very common. So for diagnosis, these are based on latex agglutination tests for cryptococcal antigen in serum or CSF. So usually, systemic cryptococcosis requires immediate treatment with amphotericin B and flucytosine or fluconazole over a period of weeks or months. So far, there is no vaccine available for cryptococcosis. So I think this is my last slide. Tetanus. Tetanus is caused by Clostridium tetani. Tetanus is a neuromuscular disease whose alternate name is lockjaw, which refers an early effect of the disease of the jaw muscle. The etiologic agent is Clostridium tetani, which is a common resident of cultivated soil and gastrointestinal tract of animals. It is a gram-positive spore-forming rod. The endospores is produced often swelling of the vegetative cell. The spores are produced only under anaerobic condition. So the Clostridium tetani class releases powerful neurotoxin called tetanus plasmin, this one, that binds to the target site of the peripheral motor neurons, spinal cord, and brain, and then sympathetic nervous system. The toxin acts as blocking the inhibition of muscle contraction. Without inhibition of muscle contraction, the muscle contract uncontrollably, resulting to spastic paralysis. The first symptoms are clenching of the jaw, followed by succession by extreme arcing of the back, flexion of the arms, and extension of the leg. So lockjaw confers the bizarre appearance of rhesus sardonicus or sardonic grin, which looks like glass and eerie, as if the person is smiling. So that's the most common clinical manifestation of tetanus. Death most often occurs due to paralysis and the respiratory muscles and respiratory arrest. So a patient with clinical appearance suggestive of tetanus should immediately receive antitoxin therapy with human tetanus immunoglobulin and penicillin G. So, according to WHO class and CDC, the recommended vaccination series for 1 to 3 months old babies consists of 3 injections of your DTaP, your diphtheria, tetanus, and cellular pertussis, given 2 months apart, followed by a booster dose of 1 to 4 years later. So, additional protection against neonatal tetanus for babies may achieve by vaccinating pregnant women whose antibodies will be passed to the fetus. Toxoid should also be given to the injured person who have never been immunized and had not completed the series or whose last booster was received more than 10 years previously. The vaccine can be given simultaneous with positive immunoglobulin vaccination to achieve immediate as long-term protection. So, again, erase the notion class that pag if you have wound caused by rusty nail, it will cause tetanus. No, it's not correct. Rather, tetanus is associated with soil contaminated infection. So hindi sa nails na rusty. Walang kinalaman sang rusty nails dun sa makakos ng tetanus. Binibigyan ka ng tetanus toxoid para ma-prevent na magkaroon ka ng tetanus na infection. So again, clinical features, Rhasus sardonicus, so that's it. That's end my discussion. I hope you learned something, and these are the references I use. Okay, thank you. And if you have questions, feel free to drop an email or feel free to message me on my Facebook account. on my rad Facebook account. Thank you and good luck on your exam. Keep safe, everyone.